Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes. Today we'll finish off this topic of diabetic kidney disease. Okay, so let's continue the remaining part. Let's begin with the name of Almighty. So we will discuss from the first part to discuss is the pharmacological management of diabetic kidney disease. This is already we have discussed in the previous video. What we are going to discuss in this is nothing but drug dosages and their titration and when to avoid, what are the key adverse effects and how to monitor. So these we are going to discuss, okay, in this table. So goal of the therapy is to reduce the albuminuria, slow the CKD progression, prevent cardiovascular events, okay, and improve survival and quality of life. In that first class of drugs which we are going to start to a CKD patient is Rais, that is AC inhibitors or ARBs. Okay, first line if there is hypertension plus albuminuria. So what is the dose? So lisinopril, the dose is 10 to 40 mg. Enalapril, the dose is 5 to 50 mg. Avoid in pregnancy bilateral renal artery stenosis if there is history of angioedema. Key adverse effects are hyperkalemia, dry cough due to bradykinin accumulation, and acute kidney injury. So these are the adverse effects. So ARBs, low sartan, candesartan, important ones. Low sartan dose is 50 to 100 is the maximum. Candesartan is 8 to 32 mg. And one more commonly used is telmisartan. Tell me the doses is 40 to 80 mg. Okay, and olmesartan, that is 20 to 40 mg. So these are the dosages. Okay, again same, avoid in pregnancy bilateral renal artery stenosis and don't use along with AC inhibitors. Here you don't have don't have a history of actually cough. This dry cough is not there. There is no dry cough with the use of ARBs. Okay, that is one advantage. So hyperkalemia, key adverse effects, symptomatic hypotension and AKI, almost same. So how to monitor? Measure systolic blood pressure, serum creatinine and potassium at 2 to 3 weeks post initiation or dose escalation. Okay, one important pearl, relaxes these AC inhibitors relax efferent arterioles to decrease the glomerular hyperfiltration pressure. ARB is standard first line alternative in patients who develop an ACE induced dry cough. Again here also check SBP, creatinine, potassium at 2 to 3 weeks or whenever you adjust or increase the dose of these drugs. That is the first drug. The second drugs which and this is one pearl, don't combine both. Okay, second group of drug is SGLT2 inhibitors. Okay, we are going to start in these DKD patients. Dapagliflozin dose is 10 mg, EMPA is 10 to 25 mg maximum dose. Okay, Cana is 100 to 300 mg dose maximum. Okay, remember how to initiate. You will initiate only when the eGFR is equal to more than 20. Do not initiate if the eGFR is less than 20. Common adverse effects are genital mycotic infections, euglycemic diabetic ketoacidosis, urinary tract infections, and in some cases volume depletion, especially when there is volume depletion states like acute vomiting and diarrhea. Okay, so fungal infections, mycotic fungal infections, genital fungal infections, euglycemic diabetic ketoacidosis, urinary tract infections, and volume depletion. So a transient eGFR dip of less than 30% in the first 2 to 4 weeks is hemodynamic and should not prompt drug cessation. Hold SGLT2 inhibitors during acute illnesses and major surgeries. Okay, the third drug which we are going to start is finerenone, non-steroidal mineral receptor antagonist. When to add? It is an add-on therapy to maximum tolerated AC inhibitor or ARB in patients with type 2 diabetes mellitus. It is added when the condition is to add when the eGFR is more than or equal to 25 and still the patient has persistent albuminuria. Even after using this ARB and SGLT2 inhibitors, the patient has albuminuria, then you should start this finerenone. So how to start? The dosage is 10 and 20. If the eGFR is between 25 to 60, then the dosage is 10 mg. 10 mg. And if the eGFR is equal to or more than 60 mg, then the dose is 20 mg. That means if the patient has G2, then the dosage is 20 mg. And if the patient has less than G2 category, less than 60, but above more than 25, then you should go 10 mg of finerenone. Okay. Do not start if eGFR is less than 25, serum potassium is more than 5. This is also important. And if there is concurrent adrenal insufficiency. So commonest adrenal insufficiency is in patients who takes who are on steroid misuse, for some arthritis or asthma, okay, or some allergy related conditions. They take steroids, okay, and they develop secondary adrenal insufficiency. So in those cases also you should not start finerenone, okay. Strong CYP3A4 inhibitors you should not start. If the patient is on strong CYP3A4 inhibitors, should not start finerenone. For example, in patients who use anti-epileptic drugs like eptoin, meaning what you call phentoin, okay, carbamazepine, okay, valproic acid, all these are CYP3A4 inhibitors, okay. Okay. Major adverse effects are hyperkalemia, symptomatic hypotension, and reversible acute kidney injury similar to ACE inhibitors and ARBs. Check serum potassium at 1 month, then at every 4 months thereafter. Every 4 months thereafter. Okay. Then we are going to add GLP-1 receptor agonist if the glycemic target is not met. How you will start semaglutide titration? You will give 0.25 mg subcutaneously weekly for 1 month. Then you will give 0.5 mg subcutaneously for second month. Then 1 mg subcutaneously weekly in the third month, and you will continue the same dose of 1 mg as maintenance dose. But this should be avoided. This is all rare actually. Personal or family history of medullary thyroid carcinoma, MTC, or multiple endocrine neoplasia type 2 syndrome, MEN2 syndrome. Okay. Major adverse effects are severe nausea, vomiting, and diarrhea, and these are usually dose limiting, and they will resolve when the body adjusts to these agonists. Okay. Initially, that's why we are starting these drugs at low doses, so that the patient can adapt to these drugs. So severe nausea, vomiting, or diarrhea, dehydration induced pre-renal AKI, and a rare complication adverse effect is pancreatitis. Clinical pulse: prioritize over insulin to meet glycemic and cardiorenal targets in patients with type 2 diabetes. So whenever a patient of diabetes mellitus CKD, always prioritize GLP-1 agonist over insulin. This is to be remembered. No adjustments required for renal impairment. This is also important point. Ensure adequate oral hydration. This is very important point. Adequate hydration the patient should have. Then we will, so glycemic target, then we will take measures so that secondary cardiovascular events should not take place. So for that we will start statins. So atorvastatin at a dose of 20 to 80 mg OD, and rosuvastatin at a dose of 10 to 40 mg. Okay. Avoid inactive decompensated liver disease. So if any liver abnormality is there in patient, for example, in patients who take who have alcohol misuse, or due to some autoimmune disorder of liver, then you should avoid. Unexplained persistent transaminase elevations, then also you should avoid. That means when you are starting statins, you should have a LFT baseline. Okay. Major effects are myalgia, myopathy, rhabdomyolysis sometimes, and new onset hyperglycemia, mild risk. New onset this is seen in the practice actually, and particularly with fibrates you will see this hyperglycemia. Okay. So adverse effects of statins are mainly on liver and muscle, mainly skeletal muscle. Okay. Targets are, lipid targets are less than, the routine target is less than 80, and if overt cardiovascular disease present, then it is less than 70. Consider dose reduction of statins in patients with eGFR less than 60, meaning less than G2, similar to your finerenone. Okay. And one more thing is, if the BP is not controlled, so the normal routine target is less than 120 SBP, and relaxed target is less than 130 or 140 for frail individuals. Okay. So if not achieved, you should add calcium channel blocker, DHP, CCB you should add. Okay. Still not controlled, then you can give thiazide type of diuretic. Still not controlled, again you can give if there is hyperkalemia or edema developing in the patient, then you can give loop diuretics. Okay. Still not controlled, then you can try alpha blockers. Okay. Alpha 1 blockers like trazocin, okay, doxazocin, these things. Okay. So that's about the therapy. and dosages and how to titrate and what to monitor. So we'll start with ACE inhibitor or ARB, titrate to maximal tolerated dose, then add SGLT2 inhibitors if the eGFR is still more than 20. Remember, both ACE inhibitor and ARB cause a transient decrease of eGFR of less than 30% of the baseline. Both will cause. Okay. So if there is less than 30% decrease of eGFR, you should not stop this. That's one thing. Then add finerenone if still there is persistent albuminuria at a maximum dose of ARB or ACE. The condition is eGFR should be more than 25. Add GLP-1 receptor agonist if the glucose is not met target. Okay. And add statin therapy for cardiovascular benefit. And for hypertension, already discussed. Okay. So ultimate goals are to reduce cardiovascular events, reduce albuminuria, slow CKD progression, prevent kidney failure, improve survival quality of life. Okay, that's all about drug dosages and their titration. Then some special situations. Diabetic kidney disease in pregnancy. Diabetic kidney disease in pregnancy. So there is teratogenic risk in pregnant ladies because you can't give ACE inhibitors, ARBs, SGLT2 inhibitors, non-steroidal mineral receptor antagonist and statins in these ladies who are pregnant because they are associated with fetal toxicity, renal dysgenesis, and skeletal malformations. That's why they are contraindicated during pregnancy because of all those standard first line drugs, ACB, ACE, ARB, SGLT2, MRA and statins. So whenever a patient is planning to become pregnant, so you should have a pre-pregnancy management. Women of childbearing potential with DKD must utilize highly effective contraception. Discontinue these therapies immediately. Which therapies? These therapies. Immediately when planning or upon confirmation of pregnancy. Now, what alternate drugs we should use if we don't use these things? Transition patients to pregnancy safe antihypertensive regimens like methyl dopa, labetalol and nifedipine. So commonly used are these things: labetalol and nifedipine for BP control and insulin for glucose control because insulin doesn't cross the placenta. And then monitor. So you should have a planned conception. These ladies should have a planned conception. Okay. They should take regular oral contraceptive pills or any other contraceptive method. Okay. And when they are planning, they should stop and they should have alternative drugs started and they can conceive at that time. Pregnancy can cause rapid severe progression of background diabetic retinopathy, increases the risk of preeclampsia. Okay. Pregnancy can cause rapid severe progression of background diabetic retinopathy, severe risk of preeclampsia. So conduct dilated eye examination every trimester, meaning every 3 months you should conduct fundoscopy and maintain close blood pressure monitoring because there is a high risk of preeclampsia. So eyes and BP are at risk. You should monitor every trimester. You should these ladies should have fundoscopy. Okay. Now coming to advanced renal impairment, like in stages G4 and G5. G4 is nothing but less than G4 is nothing but a stage between 15 to 30. G5 is nothing but less than 15. Okay. So what should we do? Metformin management. Metformin must be held or discontinued permanently once eGFR falls below 30 to mitigate the risk of lactic acidosis. That one thing we should do. Now what about SGLT2 inhibitor? Do not newly initiate an SGLT2 inhibitor if eGFR is less than 20. However, if the patient is already taking an SGLT2 inhibitor and tolerating it well, it is highly recommended to continue the drug as the eGFR falls less than 20, continuing until the initiation of chronic dialysis or renal transplantation. Okay, this is very important point. Finerenone. Discontinue or hold finerenone if eGFR drops less than 25 due to an elevated risk of severe hyperkalemia. Transition to interprofessional care. Monitor patients using the KFRE, meaning kidney failure risk equation, to predict the 2-year, 5-year absolute risk of progression to end-stage kidney disease. So if the 5-year KFRE risk is more than 5% or 2-year risk is more than 10%, then you should refer the patient to a kidney specialist. Patients with diabetes often require the initiation of renal replacement therapy, meaning dialysis or transplantation, at a higher GFR than patients without diabetes due to severe refractive fluid overload, uremic symptoms, or diabetic gastroparesis. Okay, key takeaway is individualize always the therapy, monitor closely, and adjust treatment based on pregnancy status and kidney function to optimize outcomes and ensure patient safety. So these these are the things we should keep in mind in advanced renal impairment. You should discontinue metformin, and some things about SGLT you should continue if it is already started. If it is, don't newly start SGLT2 inhibitors. That's all. Findone should be discontinued once eGFR reaches 25. Okay, and patient should be referred depending on the KFRE score. Now this is a summary which we have discussed till now. Diabetic kidney disease. A clinical diagnosis of chronic kidney disease in a patient with diabetes defined as a persistent eGFR less than 60 and or UACR more than 30 confirmed on at least 2 of 3 spot urine tests over a 3 to 6 month period. What is the core mechanism? Hemodynamic mismatch, raised intraglomerular hypertension. That is one. Second thing is glucotoxicity, active glycation, glycation end products, and PKC activation, protein kinase C activation, and polyol pathway. That is the second. Histopathologically, first there will be GBM thickening, glomerular basement membrane thickening, then mesangial expansion, then development of sclerosis, that is Schimmelstein-Wilson lesions, then there will be nephron loss and interstitial fibrosis. That is the mechanism. Okay, and then red flags. So dual RAS blockade you should not do. ARBs, ACE inhibitor, and aliskiren. So either of these three, in these three, don't start any 2 drugs at a time. Okay, at a time meaning any time. Okay, that is very dangerous. That can precipitate severe hyperkalemia or hypotension or even AKI also. Benign EGR dip continuation. So already you know, when you start SGLT inhibitors, there is less than 30% drop of eGFR. Metformin lactation. Whenever the patient eGFR falls less than 30, stop metformin. So this is an algorithm for the management. Identify and treat transient confounders first. Okay, before taking UPCR and eGFR, you should exclude this thing: UTI, menses, okay, severe hyperglycemia, exercise, fever. Once these are excluded, check for NDRD red flag phenotypes like diabetes less than 5 years or active urinary segments, active RBCs, dysmorphic RBCs, absent retinopathy. If red flags are present, then it can be if red flags are absent, then it is probably diabetic kidney disease. If red flags are present, then refer to nephrology for biopsy. So if red flags are absent, so 2 things. So these confounders so that these are accurate. Okay, so 2 samples you should take and you should exclude the red flags. So red flags are excluded and these are confirmed, then you should optimize hypoglycemia less than 7% or more and SBP less than 120. Evidence-based therapies like SGLT inhibitors, metformin, and GLP-1 receptor agonist, and finerenone. One more thing. That's about the summary. Okay. Now we will move on to we will discuss 2 practical case scenarios of diabetic kidney disease, and then we will end this topic. The first case scenario. So here is a patient, 58-year-old man with type 2 diabetes mellitus of 12 years. So diabetes mellitus is 12 years, which is more than 5 years. That you should know. Hypertension for 10 years. Weight 82 kgs and he is a smoker. Current medication: patient on metformin 1 gram BD maximum dose, glimepiride 2 mg once daily, amlodipine 5 mg once daily. Symptoms of the patient: bilateral pedal okay, foamy urine but no fever. So you should exclude these things. No, there is no fever, there is no hematuria, there is no NSAID use. On examination, BP is 154/92, which is raised. Heart rate is 78 per minute. BMI is 29 and there is mild pedal edema. So we are what are the investigations? HbA1c is 8.4, so it is poorly controlled. Creatinine is rate 1.6 mg per deciliter. eGFR is decreased less than 60, so it is 48. So it is G3A actually, G3A, and UACR is 420. Oh, so it is A3. So this, like this, you should score G3A, A3. So this is the score of this patient. Potassium is 4.5 in the range. LDL is 104. It is raised, so it should be less than 80 actually. So because we have confirmed our diagnosis of serum creatinine, because eGFR is also less and UACR is also raised, and there are no confounding factors. So we are doing fundoscopy for this patient. Diabetic retinopathy is present, so we are 99% sure that the patient is having DKD. but in urine there are no RBCs and no casts. So this is also very important. Okay, if these are present, then there is a probability of NDRD. Okay, now, so diagnosis: type 2 DM, CKD G3A3C. Like this you should write: CKD G3A3. Diabetic kidney disease along with hypertension. What are the goals? HbA1c should be less than approximately 7%, BP less than 120, SBP, LDL less than 70. Okay, why? Because the patient has a 10 atherosclerotic cardiovascular risk disease. Albuminuria, maximum reduction, slow CKD progression, and prevents cardiovascular events. So first we will say lifestyle therapy from today: less salt less than 2 grams, protein 0.8 gram, exercise more than at least 150 minutes per week, weight reduction, and stop smoking. That is important. Then we are coming to the medications. So first we are stopping amlodipine. We are giving low salt and 50 mg OD. After 2 to 4 weeks, we are increasing 100 mg OD to maximum tolerated dose. And we will monitor after 2 to 3 weeks. What we are monitoring? BP, creatinine, potassium. So we will continue these drugs, this losartan, until creatinine is increased, so that the eGFR is more than 30%, or if there is severe hyperkalemia, I mean potassium levels more than 5.5. This is severe hyperkalemia. Okay, so we are starting SGLT2 inhibitor also. So eGFR is 48, so it is more than 20, so the patient is eligible. So empagliflozin 10 mg OD or dapagliflozin 10 mg OD. Now when we have started SGLT2 inhibitor, the eGFR is reduced, see, from 48 to it is 44. So there is 8% reduction, which is acceptable, which is less than 30%. So we will continue the drug. Okay, now if eGFR drops more than 30%, then assess dehydration, hypotension, NSAIDs, and obstruction. Okay, NSAIDs and obstruction, meaning causes of pre-renal, renal, and post-renal causes we should assess if eGFR falls more than 30%. If there are no cause found and still the eGFR is more than 30%, then we should think that the culprit is SGLT2 inhibitor. Now metformin, eGFR is 48 and the patient is in 1 gram BD. Okay, and he is in G3A. Okay, because the patient is having diabetic kidney disease, that the maximum dose becomes 1 gram now. So that's why we are decreasing the dose to 1 gram per day. Now we will stop the metformin when the eGFR falls less than 30%, when less than 30, sorry. Sulfonylurea, patient is on glimepiride. So high risk of hypoglycemia in patients with DKD. Remember, the degradation, the metabolization of sulfonylureas are reduced in DKD patients. That's why we should not give these sulfonylureas, long-acting sulfonylureas, to these patients. Okay, so we are stopping this. We will discontinue this in this patient. GLP-1 receptor agonist we are starting in this patient because the HbA1c is still 8.4. So semaglutide we are starting, and we have achieved 1 mg dose. Okay, and statin we are starting as a primary measure to prevent cardiovascular events. So atorvastatin 40 mg daily at night, and the goal is LDL less than 70. Now the follow-up visit. So what is there in the follow-up? After 3 months, you should follow up after 3 months. But when you are starting ACE inhibitors and SGLT2, you should follow up after 1 month, and you should check creatinine, SBP, and eGFR. Okay, that you should monitor. After 3 months, we are seeing, so BP is controlled now, 128/76, excellent. Okay, and HbA1c is 7.2%. Okay, eGFR is 46. USR is still raised, so it is, I think it is A2 now. From A3 to it is A2. Potassium is slightly raised, it is 4.8. So response is good. Continue the treatment. Now 6 months later, again we are evaluating the patient. Now the USR is 190. Again it is in the A2 range only. Okay, and eGFR is 42. The patient is stable, slightly reduced, meaning how much? It is 8 to 10% reduced. Okay, then that is acceptable. Potassium is 4.6. Okay, acceptable. Now because there is persistent albuminuria despite maximum dose of ACE inhibitors, patient is eligible for finerenone because the eGFR is more than 25. So we are starting finerenone because the patient eGFR is less than 60. So the dose is 10 mg per daily. Repeat potassium and creatinine after 4 weeks. If the potassium is normal meaning it should not go more than 5.5. Okay, increase the dose to 20 mg daily. Okay, we start with 10 mg and we will increase to 20 mg. If it is raising, don't increase the dose. And even if it is very much raised, if it goes more than 5.5, even you can half the dose also. That's you should adjust based upon your patient. Okay, now blood pressure is still high. For example, in this patient it is not so high, it is less than 130. Okay, but for example, if the patient BP is 138 by 80, even after starting low sartan SGLT inhibitors, then we will give patient amlong. We are starting calcium channel blockers to this patient, and if needed, we will increase the dose to 10 mg also. If there is resistant hypertension, then we will add chlorthalidone or a loop diuretic if the patient is in advanced CKD to reduce the risk of hyperkalemia and fluid accumulation. Long-term monitoring is every 3 months the patient should have HbA1c checked, eGFR checked, potassium checked, BP checked. Okay, every 6 months the patient should have UACR and lipids checked. So it is every 6 months. Okay, so in normal patient actually it is every year. Okay, every year, but in this DKD patients it is every 6 months, lipid profile and UACR. Yearly eye examination should be done, foot examination should be done, vaccination review should be done. Okay, so these are the things. So this should be remembered. The follow-up thing we should be remembered. One, just to revise, so every 3 months we are checking eGFR, potassium for kidney function, BP and HbA1c for glycemic target and BP target. Okay, we are testing for glucose level, BP level and kidney function. Every 6 months we are checking for UACR and lipids. Every 6 months we are checking for UACR and lipids. Then every yearly we have eye examination, foot examination. Okay, so the final medication regimen in this patient is low sartan 100 mg OD, empagliflozin 10 mg OD, metformin 1 gram BD. Okay, BD, no, it is not BD, it is actually OD. Okay, this is not BD. Semaglutide 1 mg weekly, finerenone 20 mg OD, atorvastatin 40 mg OD. Expected outcomes after 1 year is HbA1c should be 7% at least, BP should be less than 120, LDL should be less than 70, albumin should be reduced by 30 to 50%. So slower annual eGFR decline should be there. What is that slow? What do I mean by slow eGFR decline? That should be less than 5. So yearly the eGFR should decrease by less than 5, or you can say, okay, that is 5. Okay, then that's the thing. Okay, early initiation of guideline directed therapies, regular monitoring and timely dose titration based on response and tolerance are the keys to slowing DKD progression, reducing cardiovascular risk. This is guided by the ADS Standards of Care in Diabetes 2026, KDIGO Guidelines 2024. Okay, that is first case. Now we are going to a second case, which is the last case. See, this is a patient, 62-year-old male, elderly, 12 years, more than 5 years. Okay, hypertension for 10 years, obese patient, 31. He is on metformin 1 gram twice daily, amlodipine 5 mg. So we are checking BP is above the goal, HbA1c again above the goal, eGFR is 45, so it is G3A, UACR is increased, so patient is having DKD, I think. But so metabolic panel, potassium is baseline 4.5, creatinine is 1.6, so it is raised, so it is DKD. Lipid is 95. Target treatment goals established. Blood pressure should be less than 130. Why? Because the patient is elderly, more than 60 years of age. Okay. Glycemic control, HbA1c less than 7%, or because the patient you can go up to less than 7.5 to 8% also. For renal cardiovascular protection, reduce the albuminuria and mitigate the decline in eGFR. So how we are doing here, you just see. So first thing, initial intervention foundation therapy, 0 month. Foundational therapy for type 2 diabetes include AC or ARB, SGLT2, statin and lifestyle modifications. Action plan, starting low sartan 50 mg daily. Okay. Then dapagliflozin 10 mg daily. Then atorvastatin 20 mg daily. So low dose we are starting. And lifestyle modification, sodium restricted diet, moderate protein intake, weight reduction, physical activity, smoking cessation. Okay. Then phase 2, in the first month, after 4 weeks, BP is 138 by 82, potassium is 4.8 milliequivalents, creatinine is 1.8, so eGFR is now 41 actually. It is reduced, but less than 30%. So because it is less than 30%, we are continuing the therapy. But because the BP is still raised, we are increasing the low sartan dose to 100 mg daily. Okay. Then after 3 months completed, the BP is 128 by 78, target is achieved, HbA1c is 10.4% acceptable. Okay. USCR 180, it is improving. Okay, USCR is 180. Initially it was more than 300. Okay, potassium is 4.7. Okay, eGFR is 40, stabilized. Okay, action plan, because HbA1c is not under the control, we are starting semaglutide to this patient. Okay, after 6 months, every 3 months you should review the patient. BP is 124. So now HbA1c is raised to 6.8%. USCR is persistent. See, 150 it is. Oh, again it is in A2 only. Potassium is 4.6 and eGFR is 40. So because the proteinuria is still present, we are starting finerenone 10 mg daily because the eGFR is less than 60. Okay. Then if after 1 month, if there is no hyperkalemia after starting finerenone, then we'll double the dose of finerenone, that is 10 to 20 mg. Final regimen maintenance dose after 9 months, metformin 1 gram, not BD, it is OD. Okay, mistake by. Okay, it is OD. Metformin 1 gram OD. Losartan 100 mg daily, dapagliflozin 10 mg daily, semaglutide 1 mg weekly, finerenone 20 mg daily, atorvastatin 20 mg daily. Okay. So adjust dose if eGFR is less than 45. Discontinue if eGFR is less than what? Metformin. So okay, that is the thing. Ongoing monitoring plan. After any dose adjustment, losartan or finerenone, check baseline metabolic balance, basic model, that is potassium, creatinine 2 to 4 weeks. Every 6 months, monitor USCR to assess response to therapy. Monitor USCR. So USCR is actually every 6 months and eGFR is every 3 months. Okay. Annually diabetic eye and diabetic foot. At every visit, BP, weight, adherence, side effects, lifestyle. Key takeaways: early initiation of potential RAS blockade, SGLT inhibitors, GLP-1 receptor agonists, and non-steroidal MRA, along with lifestyle medication, consistent monitoring, reduce the risk of CKD progression, kidney failure, cardiovascular events in patients with DKD. That's all about DKD. Thank you.